Brief overview of clinical photography. Before we start, just a little bit about myself. My name is Ian Hutchinson and I'm a registered orthodontist in the UK. I qualified from the university in Newcastle upon Tyne, which we're famous for the Millennium Bridge. I'm a member of the British Lingual Orthodontic Society and I help give presentations on lingual appliances and orthodontics both in the UK and other places around the world. My practice is based in Chepstow, which is in Wales, which is part of the United Kingdom. Have quite lucky in that just have one chair per surgery or per room, so it's quite quiet practice, and I treat mainly adults. Now, getting back to the subject of clinical photography, what we'd like to do is take a walk through why take images, help explain some of the technical terms, go through what you need to take good clinical illustrations, how to do it, and just touch on some frequent errors. Now, I have to say, once you start getting into clinical photography, you'll probably end up taking more and more holiday snaps. And this was taken in Monte Carlo, where we were given a course. And what we're doing is altering the aperture and shutter speed to get the water from the fountain opposite the casino in focus. So just to warn you, photography does become a little bit addictive. And of course, whilst on holiday, there's always one person, shall we say, and obviously you've got to take a photo. Anyway, getting back to dentistry. There is some evidence to say that the quality of your dentistry is linked to the quality of your clinical records, and part of these clinical records is clinical photography. Also, pictures, people can relate to pictures much more than words, myself included. I tend not to read the instruction book but to look at the pictures. So to help communicate to your patients, it's an invaluable tool to have a portfolio of before and after cases, so the patients can quickly grasp what you're suggesting or proposing for their treatment and what they can expect at the end of it. Equally, photography helps communication, and this was a lingual case which was using the bracket positioning device, BPD, and the torque angulation device, TAD. So basically it's a way of positioning the brackets on the teeth without doing the classic class setup. However, you'll notice the brackets are all at different heights, and the technician didn't really understand until we took a photo and sent it back to him. And what it turned out was that he had the torque angulation device, but he didn't have the bracket positioning device because he thought he could do without it. So it helped explain to him why he needed both bits of equipment. Oral pathology. Here's a patient, although the photograph is faded because this is taken from a 35mm slide, shows how long we've been taking photographs, of a patient that was allergic not to nickel, not to latex, but to BIS GMA composite. So I've had 4 patients in my clinical history have been allergic to BIS GMA, and taking photos helps communicate with the dermatologist the nature of the allergic reaction, and obviously oncology would be ideal, or white patches, leukoplakia, and seeing how they change over time. Orthodontics is slow and patients often don't appreciate the change. So taking photographs can help show the patient the progress and help motivate them again. And this was a picture of a patient who wouldn't want any teeth out because his mum wouldn't let him, and he didn't want to wear braces because he was a young teenager. So basically we did some distalization in the lower arch using a TAD mini screw to distalize the molars. And you can see here why you need to keep the wire long, because as we've distalized the 6 and the 7, or the first and second molar, the arch wire slipped out of the tube and the 6 has tipped. But you can see the distalization that's occurred, which has allowed the premolar to be aligned. If you get into teaching, I never thought I would undertake teaching, but it can be quite helpful. So here's a patient who has been refused treatment by numerous clinicians because she only has 6 teeth, and we need to intrude and procline the lateral and the canines. Because she hasn't got a full arch, can't use fixed appliances. In the UK, mini screws weren't that popular at the time, and this is the result we achieved. So how did we achieve it? Quite simply, placed a single mini screw, bonded the canine and the lateral together with some fibre reinforced composite, and just pulled. And because there's an intrusive force, the teeth will obviously intrude, and then we can jump the bite. And the reason the teeth jump the bite is because the force is in front of the centre of resistance, so we've created a moment to procline the teeth. Again, for teaching, a patient was referred wanting some implants in the lower arch, so the dentist has asked me to intrude the 2 premolars to give some vertical space. Now, in the previous slide, we saw how the teeth would procline if you pull from one side. So obviously there's a mini screw on the palatal side of this patient. Why else take pictures apart from teaching and pathology? Well, obviously to encourage the patient. Hopefully they'll take ownership of the problem, so when you disclose them they can see the plaque, and we all know how accumulation of plaque and poor oral hygiene and diet leads to decalcification, so we can show the patient images of what will happen if they don't improve. Sometimes the patients don't appreciate the nature of the problem. Here we can see there's a tooth size discrepancy. One central incisor is larger than the adjacent one. So again, we can show the patient, and perhaps if you've done some digital smile design, you can put some templates on the teeth to illustrate what the teeth should be or the appropriate size. And indeed, this picture is taken from one of my keynote presentations I give to patients of the treatment plan, showing problems with the gingival margin heights and how we need to intrude some teeth and to improve the smile arc. And again, some templates to show the appropriate tooth golden proportions and sizes. We've mentioned about before and after, so they can see what to expect. And also, obviously this portfolio is great for helping cell treatment. Medico-legal issues, big problem in the UK because we're now the most litigious dental sector in the world. So we've got to protect ourselves, so decalcification. Sometimes one of the complications of orthodontics, as we know, is devitalisation. And here's a tooth with an upper lateral incisor that has devitalised due to the lingual appliance. So just taking a picture to show the patient, and then we can undertake a root canal and then some whitening. And obviously marketing. Many of the companies, these are taken from Ormco, have very glossy images, and indeed some clinicians will send patients to a photographic studio to have their hair and makeup done to help complement their new smile and help market it. Now, as I mentioned earlier, I've been taking photographs for many years, and at the time we had to use film. So all our images were taken on 35mm film and turned into slides. Digital has been absolutely fantastic because it means we've cleared out rooms that were full of slides. So digital has obvious advantages. Other advantages include that you can see the picture straight away. We had to send the films away and wait 2 weeks before they returned, only to find there's a problem. For example, some food on the patient's teeth or the nurse's fingers in the film. So that meant with digital, you could take a new image there and then because you can assess it immediately. Obviously it's cheaper because you haven't got to buy the film or pay for the processing. And to be honest, the cameras are about the same price now as they were then. There's no problems with having a spare room with filing cabinets because you can simply put it onto a portable hard drive. And that means you can duplicate these pictures easily, so you can give them to the patient, or you can use them for your own presentations and teaching. Like I've mentioned earlier, my treatment plans aren't sheets of written terminology and appliances. They are pictures, as I find many patients are visual. They prefer to look at pictures than to read pages and pages of text. So it helps motivate them, especially if you've got a close-up of their teeth. And there is some, well, let's say kudos to having a big camera. Most general practitioners in the UK don't. So when you start taking photographs with a 35mm SLR camera, it does help impress the patients. Now we'll just touch on some technical terms, and these are the terms we'll walk through and help hopefully clarify them for those who aren't too familiar. Now, the easiest way to think of the function of a camera is to think of an eye. The shutter of the camera is your eyelid, so you can have a slow blink or a quick blink, and obviously that will affect the amount of light that enters into the eye through the pupil. And we all know pupils can be dilated or constricted, and this is equivalent to the aperture setting of the camera. And by controlling, or I should say mixing blinking with the size of your pupil, you can alter the amount of light and hence the quality of the image that enters your eye. Same as with the camera. So the exposure is a combination of the speed of the blink or the speed of the shutter and the size of the hole or pupil or aperture. And by altering them, we alter the light. So you could say, well, why don't we slow the shutter speed to let lots of light in and have a big aperture to let lots of light in, and we won't need a flash gun, or we could use the dental light. Problem with this is that it just doesn't work. If you have a slow shutter speed, you get camera shake because you can't hold the camera steady enough. And if you have a large aperture, large pupil, that affects the depth of field, or how much focus. So you could have the central incisors in focus, but the rest of the dental arch is blurred. So to overcome that, we need more light. How do we get more light? Have the flash. And what does the flash allow us to do? It allows us to make the shutter quicker, so we don't get camera shake, and it allows us to make the aperture smaller, so we get more depth of field in focus. Now the aperture can be a little bit confusing. It's used or described as an f-stop, and the bigger the number, the smaller the hole, or smaller the aperture, which seems a little bit strange, but once you get used to it, it's okay. So what we tend to do for dentistry is use an f 5.6 or 6 for facial shots, and f22, so a much smaller aperture, for intraoral shots, because we need more or greater depth of field. And by altering this f-stop, we then have to calibrate the camera by altering the shutter speed so we get the appropriate amount of light. So here's an example of depth of field. So you can see in the center of the image, it's in focus, but as you go away or towards the camera, it becomes out of focus or blurred. This is no good. As we can see here, the incisors are in focus, but the molars aren't. So this image was taken with a f 5.6, a large hole, a small number, and a very narrow depth of field results. So like I said, you really need a minimum of f22 for dentistry, for intraoral shots. So here we can see the image is a little bit dark and a little bit out of focus. So what would you do? Well, because the posteriors are slightly out of focus, we would increase the f-stop number. If we increase the f-stop number, it's going to become darker, so we need more light. So we could either make the shutter slower, but then we might be worried about camera shake, so we would need to alter the output from the dental flash. Next thing, white balance. We've all been trained or conditioned what is white, but the camera hasn't. And the camera is programmed to recognize white, but white is dependent upon the light bouncing back off the image. And the light which bounces back can vary depending on its source. So a halogen light compared to an LED light compared to a flash will all give slightly different blue or orange, if it's a tungsten normal bulb, reflection. So the camera has to be programmed to recognize what is white, and basically how you do it is there's a white balance setting on the camera, and if you generally set that to the flash mode, it'll give a good result. So here we can see an image taken with the Canon camera with the white balance set to flash. We then repeated the image but allowed the camera to automatically decide what is white. So the white balance has been set to automatic, and you can see the difference. Now with this Canon camera, personally I think the white balance looks better on auto than it does on flash. So try your own camera and see what you feel is best. Now white, typically natural daylight is 5500 Kelvin. So you can buy these natural daylight attachments. The Optilume is used for taking shades, but you can also buy an Optilume attachment for your camera. So you wouldn't need a flash, you would use these attachments. ISO. ISO is the equivalent of the grain size or film speed. The higher the number, the faster the film and the less light needed. But the higher the number, the grainier the image is, because the grains are bigger. So what we tend to use is ISO 100 or 200. If you set it on 200, then the pictures are perfectly acceptable, but the amount of light needed to create the image is half that needed for ISO 100. So what this means is that your flash will have to deliver half as much light. If it has to deliver half as much light, it's not working as hard, so your batteries will last a lot longer. So generally I set mine to ISO 200 because it's perfectly acceptable and it saves the hassle of constantly having to change the batteries all the time. What do you save the pictures as? JPEG is the most commonly used type of file. However, each time you save it, there's a degradation. The image becomes slightly worse. Also, JPEG films or files can be adjusted. So what I do now is I set the camera to record JPEG, which I shrink and use in presentations, but also RAW, which can't be adjusted in any way. The problem with a RAW image is that it's very hungry on memory. So I keep all my RAW images as a backup on a separate hard drive, just in case I need them for medical legal reasons. These days the cameras are getting more and more megapixels, and to be honest, I can't detect because the computer screens are usually 1024 in pixels. So again, what I do, like I've mentioned, is that the camera takes the image in JPEG and RAW, and then I shrink the JPEG to save memory, because if you put that image into your Keynote or PowerPoint, it would rapidly become a very large file. And also your practice or office management system will get slower and slower as you fill up all the memory with these huge files which you don't need. So always shrink your JPEG files for presentations and office management software. So what equipment are you going to have to buy? Well, there's lots of these point and shoot cameras, but to be honest, you can't beat a 35mm SLR camera with a ring flash and a macro lens. To me, this is true point and shoot once it's been calibrated, and you always get excellent images. So a Canon D400 or Nikon D40 would be a good place to start. These days, with the rapid advancement of technology, it's probably a Canon D700, simply because it's got bigger bigger pixels, more megapixels. But like I said, you don't need them. So really, get the cheapest SLR camera for a few £100 will be fine. However, you know, some people get more and more into the photography, so you can rapidly increase the amount of cash you need to spend. So you can go from a few £100 for the beginning camera to about £1,000 for the enthusiast, to a couple or few thousand for the professional model. But what's the difference? Well, the difference between them is really the build quality, the weight. The professional cameras are a lot heavier, faster shooting, so you can take more frames per second with the professional camera. But unless you're doing motorsport or natural wildlife photography, it doesn't really affect us. And also a slight difference in the grip. So unless you're into your photography as a hobby, I would just go for a beginner's camera. The other difference due to the price is the size of the sensor. The sensor is the equivalent to the film. We used to use 35mm film. The cheaper cameras aren't 35mm sensors, they're actually smaller, so there's a cropping effect. So you would get more of the image on the professional camera than you would on the beginner's camera. But like I say, with the lenses and everything, it's not an issue. The ring flash. Why do you need a ring flash? Well, you're using a macro lens, so you're very close to the teeth. So the output from a conventional flash on top of the camera is divergent, so much of the dentition is in shade or in shadow, so it doesn't illuminate. That's why you need a ring flash to illuminate the teeth and eliminate the shadows. However, a ring flash isn't brilliant for taking facial portraits because it flattens the face and you can often have a shadow. So to overcome that, you can buy these double flash, which has a ring flash and a separate point flash for taking facial photos on. Now, some people who do a lot of restorative work, like we've mentioned earlier, do like these POV lights because they're meant to emit natural daylight. So some argue it's better for shade. The macro lens, why the macro? Because it allows us to get closer and take more detailed shots like we can see here. And if you acquire a 100mm or 105mm macro, you can literally go 1:1 and take very detailed close-up pictures, especially for restorative needs. you don't have to purchase the brand of camera macro lens. You can buy cheaper ones, such as Sigma or Tokina, but you do need to make sure it's compatible with your Canon or with your Nikon camera, because the electronics are slightly different. So buying a cheaper lens can save you a little bit of money and will work fine. Like I said, you've got to remember the settings, so you may just want to place some little adhesive labels on top of the camera to help remember. For example, intraoral is f22, 1/500th for the flash, sorry, 1/500th for the shutter, and the flash on quarter power. And for the magnification, again, so the pictures have a constant magnification. The focus is by you. You have to move. You don't turn the lens to focus. So you keep the magnification constant and you move forwards or backwards until the teeth are in focus. Then you take the image. Now, I mentioned compact cameras are available. They have a problem with light output, and you can't use a ring flash, so you can have all these LED attachments. But to be honest, they're more trouble than they're worth. Just buy an SLR camera. And we've mentioned about the POVs. Some other accessories you may need to acquire: a card reader. With the compact flash, just be careful because there's lots of pins, and the number of times we've had assistants heavy-handed push the card in and bend the pins, which then all need replacing. So just be careful if you have compact flash. Cheek retractors, I like these slightly elongated ones because it allows you to retract the cheeks more to pick up the second molars. And for occlusal images, these horseshoe U-shaped lip retractors are great. You're going to need some mirrors, lots of different mirrors available. I tend just to use occlusal ones. I tend not to use buccal mirrors, and there's various different types, as in some are glass, some are simple polished metal. Everyone has their own favourite, but I do prefer the glass ones, and I prefer them with a handle because it keeps your fingers out the way and it helps get more control over the position of the mirror. Contrasters are great because it eliminates soft tissue behind the teeth, so you can get this sort of result. It just makes it look more professional. Another accessory is a polarization unit for the light. We can see here specular reflection, which can interfere with shade and anatomy. So we can see the glossy effect, the light bouncing back off the teeth, compared to a cross-polarized image where you don't get any of this specular reflection, and the two side by side. How it works is that the light is filtered coming out of the flash, and it's filtered on its entry back into the flash. So this way it's a bit like polarized sunglasses. The wavelengths are filtered out and it's much more accurate. Another simple bit of equipment, if your dental chair doesn't move up and down, is a step, because you need to be parallel with the occlusal plane. Alternatively is to place the patient on a normal chair that is adjustable for height. Once you've got all your kit, you need to calibrate the camera. So like we've mentioned, you want to set it to ISO 200. Tend to set the flash to manual, although the new through the lens electronic metering is a lot more advanced than it used to be. Tend to set it to f22, and depending on the output of the flash, anything between 1/125 up to 1/1500. Take the image and have a look. Is it too dark? If it's too dark, make the shutter a bit slower. If it's too bright, make the shutter a little bit quicker. But you need to keep your f-stop at 22 for your depth of field. So you don't alter the aperture number. Like we said, too bright, you can make your aperture number bigger, so f29, f36, because the more depth of field, the better. And again, don't forget, if you are setting to manual, you can adjust the output of the flash. So I've just bought a new Metz ring flash and a new Canon D700, and the electronic metering is so good, I've just put it to automatic, and it's great. And don't forget your white balance. You decide what looks best. And then the magnification, usually 1 to 2 for intraoral and 1 to 5 for extraoral. So we can take pictures of teeth, we can take pictures of faces. What else can we do? Study models. Although these days, with the move to digital casts, intraoral scanning, tend not to do this as much. And similarly with radiographs, we tend to be digital now, although there's still a few places that are on film. And it's quite easy. You can just put the film onto a viewfinder, turn off the camera flash, put the camera on fully automatic, not manual, automatic, and take the image. And like I said, it's not just teeth but faces, even if you're doing beauty. And this is a patient I treated with some fillers just to show the difference before and after and help use it for marketing. So a few tips. Avoid background clutter. What do I mean by this? Well, when you're taking a facial picture, make sure the patient is against a plain background. There isn't a door frame, there isn't a light switch, or there isn't a crane in the background. It should be plain. Many SLRs have a grid in the viewfinder. This can be very helpful because it allows you to get it parallel with the occlusal plane. Try and keep your magnifications the same, so every patient has the same magnification setting, and then all the pictures are comparable. We mentioned about height. If the chair doesn't go up or down, you have to go up or down, or put the patient into a normal stool, for example, bar stool that can move up and down. Facial shots, try and avoid the shadows. And what I do is on my ring flash, I alter the output of the camera to one side and it eliminates the facial shadows. And again, try and get everything symmetrical. get the occlusal plane level and parallel. Here we can see we're too far forward, we haven't come far enough round to get perpendicular to the molars. So here, this is what's happened. We need to retract the cheeks more so we can move further around to get a better perpendicular shot. Here we can see we're too low down, so we're looking up. So the patient needs to move down, or we need to move up so it's flat. Bit like this. So canine roughly in the middle and perpendicular to the occlusal plane. Occlusal shots with the mirror, we can see the horseshoe. Here the dental chair hasn't got a knee break, so the clinician is stood slightly to the right, looking inwards. They need to be stood directly in front of the patient to get a true occlusal image, more like this. But the problems here is that the magnification isn't great enough, so we have a lot of wasted image, which we can crop. It's not a problem, but why not get it, perfect? This looks better, but the magnification's too big. We haven't got the 7s on, the second molars. Similarly here, the occlusal mirror doesn't go far enough back, and there's no lip retractor. Got the lip retractor, but it's not symmetrical. Molar on one side, not on the other side. Here the patient's breathing. Okay, we can't stop them breathing. We can warm the mirror, warm water. You can buy mirrors with a fan, quite expensive, or simply get the nurse or your assistant to blow air onto the mirror. Another problem, like we've mentioned before, is specular reflection, and we can eliminate that using the polarization unit. A sort of a ring flash. It has satellite units to help prevent direct light. You've got sort of diffuse light. Or the easiest way is to take another image at a different angle. So here we've taken looking upwards. So the purpose of this image is to show the texture of the teeth, because we haven't got the reflection. And this patient looks like there's no texture of the teeth, no tertiary anatomy, and indeed they didn't. They had quite a lot of erosion and their teeth were super smooth, hence the reason it looks so smooth. And obviously we can take black and white or convert the images to black and white, which gives a value. So for restorative cosmetic work, it can help show the texture and the luster or the polish of the teeth. So with that, I would thank you for your attention, and hopefully this whistle-stop brief overview of dental photography has proved useful. If you have any questions, then please feel free to contact me through Dukes, and happy shooting. Thanks very much.